Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone. Lovely to see you all again, and welcome once again to CATHIP's Health Hour. So welcome to our new listeners and welcoming those who are spending time with us for the first time and those that have been with us week by week, and we don't take it for granted. So just a reminder of who we are. So CATHIP is the Caribbean and African Targeted Health Improvement Program. And it's really a collaborative, educative, and empowering health literacy program that is really there to support Black communities to enable us to take control of our health and also support others. And it's made up of a number of fantastic organizations. So we've got the Caribbean and African Health Network, we've got the Black Health Initiative, we've got the Royal Assembly Redeemed Christian Church of God, we've got RAFA, International Development Agency, Croydon BME Forum, and the Enfield Caribbean Association. So thank you to all our partners. And really just reminding that these health hours are for you. They're for you in terms of us bringing fantastic professionals to come and impart their knowledge, but also it's an opportunity for you to ask any questions that you may have. So feel free to communicate with us, write in the chat, but also we'll have questions at the end. So please feel free to put up your hand and we'll engage you in the whole discussion. And it would also be great to really, for you to tell us where you are, your location, friends and family. So just today, for me, being your host, I'm Dr. Vanessa Rapier, and I'm a consultant in sexual health and HIV, and I'm based in East London. And today we have a wonderful speaker with us. And I wanted to really kind of preempt the conversation that we're going to be talking about today, because it is such an important topic, and it's one that can affect us all in many different ways, whether it's personally or whether someone in our family, our partners, in our network. But I do want to give a bit of a trigger warning, as it were, because today we're going to be talking about physical and mental health in early pregnancy and its complications. So we will be talking about miscarriages, and you know, I'm always really open about anything that's happened in my life medically, and I'm someone that in my journey to motherhood have experienced a number of miscarriages, and it's something that we don't talk about enough as a community, but also we're really aware that when we're talking about it, it may trigger some emotions. And we have our counselors based within CAHN that you can access as well. And within the talk, we'll be signposting you to online support and other organizations as well. So, but just wanted to give you that awareness. But we have the lovely Dr. Patrice Arthur, who is a doctor, obs and gynae, based in Manchester, who is going to lead this conversation. So, Dr. Arthur, thank you so much for being here, and over to you.
Okay, thank you, Dr. Apnia. Thanks for introducing me. I'm going to just start by sharing my screen. Okay. So today we're going to talk about the complications in early pregnancy. And as Dr. Apnia alluded to, it is quite an emotional topic. It's definitely something we don't normally talk about. I think people just assume it's common in women, it's a common woman's problem, and they kind of brush it under the carpet. But I think we need to start talking about this more. And we won't just be talking about miscarriages, but about other problems as well. Ectopic pregnancies, hyperemesis gravidarum, which basically means extreme sickness and nausea in pregnancy, and early pregnancy bleeding, which can cause a lot of worry and concern. So all these things can cause a lot of anxiety and can lead to low mood and depression. And it's important we discuss these topics and learn how to manage them, learn how to control them, and learn when to seek medical help. So as I mentioned, it can be a difficult time for some women, early pregnancy. And it's important to recognize these difficulties, discuss them, and seek help. For example, research shows that Black women are at 43% higher risk of miscarriage than white women. And this is taken from a research paper in the Lancet, Miscarriage Matters. So it's good that we are finding statistics about this problem. It's good that research is going on about this problem. And this is all recent. So, but it's important that we as a community try to figure out why this is happening and how what we can do to prevent it and seek help. So what are the consequences of early pregnancy complications? Well, you not only have the physical consequences, the bleeding, the loss of life, meaning the miscarriage. In terms of hyperemesis gravidarum, it's the extreme weight loss that you get during the pregnancy, and obviously that nausea and sickness. So those are the physical consequences, but you have psychological consequences as well. Increased risk of anxiety, depression. Some women can actually go through a post-traumatic stress disorder, and women with history of recurrent miscarriages can actually have suicidal tendencies. So these are things that we need to be aware of, as well as clinicians who are treating these women need to be aware of. Miscarriages can also result in risk factors for complications in pregnancy later on. So even though you do manage to carry the pregnancy, you can have complications because of the fact that you've had previous miscarriages. And these are things like preterm delivery, fetal growth restriction, basically meaning a small baby at birth and the complications of that. And there's also risk of premature separation of the placenta from the uterus. So these are the risks that women with recurrent miscarriages face. And there are also increased risk of stillbirth. There's also increased risk for long-term health problems, such as cardiovascular disease, a tendency to get clots, clots affecting the vessels in the legs, in the chest. Yeah, these are quite important and severe health problems. And we have to think of the economic cost. For example, the short-term cost of miscarriage is up to 471 million pounds per year. So it is quite an expensive problem. And this is just a short-term cost in finance, in money terms. We haven't even mentioned what the long-term costs are. So it's important we get to grips with this problem. So what are the kind of emotions that a woman can experience, the range of emotions? It could be frightening, lonely, feelings of grief and loss. Women may be anxious and worry about getting pregnant again and whether it would happen to her again. Of course, during the time of the miscarriage, or if it's an ectopic pregnancy, feeling unwell and drained after losing the pregnancy, feeling quite panicked and feeling out of control, and feeling quite angry about what has happened to you, and also angry with the people around you. Especially women could feel angry that other women that are having a wonderful time in their pregnancy, and yet they can't seem to have a successful pregnancy. And it can also trigger mental health problems like clinical depression. And as I mentioned, suicide. Relationships can be quite difficult. And some women have to come to a point in their lives where they have to think, okay, how do I move on? How do I move forward with this? This has happened several times. What sort of life am I going to have? Am I going to decide, okay, I'm not going to try again because of all these emotions and the effect on my mental health? Would there be other options such as adoption, fostering, being part of a children's charity? So these are all things that women need to sit and think about that are going through a very trying time. So let's talk a little bit about miscarriage. We know it's common. It occurs in about 1 in 4 pregnancies. And the going rate is about 23 million miscarriages yearly worldwide. Okay. About half of them are due to genetic reasons, abnormalities at the time of conception. We know that some problems are due to hormonal problems, and some women have blood clotting problems. So the placenta isn't able to implant into the lining of the womb. So these are certain problems that can cause miscarriage. The risk factors you can have 2 extreme age groups: the very young or the older woman, being more than 35 years of age. And something we don't normally associate with miscarriage, actually older male partner being more than 40 years. So these are associations they found with increased risk of miscarriage. A very low BMI, your BMI has to do with your height and weight. So very low, meaning very slim, or high BMI, more than 40, could predispose to miscarriage. Black ethnicity, surprisingly, or it may not surprise you, history of previous miscarriages. So if you've had one, there is increased risk of having a second miscarriage. Lifestyle choices like smoking and alcohol, also stress. And interestingly enough, working night shifts and working long hours can predispose you to miscarriages. Air pollution and exposure to pesticides. So these are the risk factors that was found in that Lancet study. Now, why are Black women at greater risk of miscarriage? I have a video from one of the researchers at the University of Birmingham who discusses this problem and it's an interesting take on this issue. So I'm just going to share that with you, or would you be able to share that with the group? Okay. So I'm
You
just
practiced this earlier, so fingers crossed, everyone.
yeah. Let me just. Okay.
Why are Black women at greater risk of miscarriage? What should be done? I am Eric Kumarasamy, Professor of Gynecology at the University of Birmingham and the Director of the Tommy's National Center for Miscarriage.
Sorry, are you able to hear and see the video?
We can, thank you so much.
Okay, let's go ahead.
The evidence on the association between Black ethnicity and miscarriage is presented in our Lancet series on miscarriage. We found 19 studies with over 500,000 participants that showed Black women had 40 to 60% higher risk of miscarriage compared with white women. The question is, of course, why? Well, we don't yet know. Is it because of some biological reason, or is this attributable to social factors? Is it because of medical conditions? For example, we know that fibroids are commoner in Black women. Or is it due to some lifestyle issues? We don't yet know. But we at the Tommy's National Center for Miscarriage Research are determined to find out. But while we are researching the reasons, what should be done? Well, we recommend targeted preconception care and antenatal care in specialist clinics for Black women and others at high risk of miscarriage. There are also things that women themselves can do to help reduce the risk of miscarriage by addressing modifiable risk factors. For example, achieving an appropriate body weight, cutting down or stopping smoking and alcohol consumption, eating healthy, balanced diet enriched with fruits and vegetables, and cutting down on processed meat, fat, and sugar. It is not only miscarriage risk that is increased in Black women. Other serious pregnancy complications like preeclampsia, preterm birth, and even stillbirth risks are increased in Black women. It's a research priority for us to find out why this is the case and how to reduce the risk for Black women and other high-risk women. Please join the Tommy's campaign to improve miscarriage research and care.
Okay, so I'm going to go back to my presentation. So it's quite heartening to hear that research is being done for this problem amongst Black women. And, you know, I definitely endorse what he's, saying about doing the bit that we can do as patients, as clinicians, to help reduce the risk of treatable conditions like hypertension, diabetes, that would, and obviously raise BMIs to help reduce that risk of miscarriage and pregnancy complications. So go back to my next slide. So we spoke about miscarriage, and there are some women that suffer. Fortunately, it's a very small percentage, 1%, that suffer from recurrent miscarriage, and that's about 1%. And again, the risk factors are things like age, clotting disorders, as I mentioned, which would come under thrombophilia, genetic factors, a weak cervix, that more has to do with mid-trimester miscarriages, so miscarriages more than 20 weeks, so 22 weeks, infection, and developmental problems and immune factors. What sort of investigations would the clinician be doing for you? We'll talk a bit more in detail about this, but they want to be doing blood tests to see if there are any clotting dysfunctions or clotting problems that you have. If it's a miscarriage that's your second or third, they want to do genetic tests on the fetus, and also test the shape of the uterus. So they will want to do invasive investigations to look at the inside the womb to see if there's any problem, any fibroids, any septae, anything that can cause obstruction to that implantation. And they would also want to do tests for chronic infections that can cause miscarriages. So they have devised a certain plan, an appropriate care model. So this is a model, is not happening throughout the UK, but this is the ideal model that clinicians would like to adopt. After the first miscarriage, when a patient presents after her first miscarriage, the woman should be given guided information about the miscarriage and resources to address their physical and mental health needs following pregnancy loss, and ways to optimize the health for future pregnancies. So things like patient support groups, online self-help strategies, and referral to services for management of chronic medical conditions, screening for mental health issues. These should all be put in place after one's first miscarriage. This success rate of having a successful pregnancy after your first miscarriage is still very good. It's still quite high. And unfortunately, some women may have to undergo a second miscarriage right after their first. And after the second miscarriage, you'd want to be having an appointment. In fact, before you get pregnant again, you'd have to think about preconceptual folate and vitamin D supplementation and all of that. But you'd want to be in touch with an early pregnancy unit and perhaps make an appointment with them, and have a nurse midwife-led or attend a nurse or midwife-led clinic, and they can start instituting various investigations like a full blood count, and looking at certain investigations like a thyroid function test. All these can lead to unsuccessful pregnancy if there's a dysfunction with those hormonal levels. Traditionally, we would do these investigations after the third successive miscarriage, but we are moving away from that sort of protocol and trying to refer patients even after their second for specialist care if these tests are abnormal or if a chronic problem exists. And these women need access to early pregnancy reassurance scans as well. So after the third miscarriage, unfortunately, if it goes to that, then the plan is to refer these women to consultant-led clinics, do additional tests and a full range of treatments, and test the genetics on the pregnancy tissue. These blood tests for antiphospholipid antibodies, they're basically conditions that cause clotting, and it can cause it at the cellular level of the womb. Okay. Again, you'd want these women to have access to ultrasound scans, very detailed ultrasound scans, and also looking for any genetic problems in the parents. So all these are specialist tests that would be done in a specialist center. And again, we shouldn't leave out the mental health issues with these women. These women are quite depressed and very fraught and very frightened. And we should also put in place a care plan for their mental health issues. One of the treatments that have come, progesterone has been around for a long time, but this study has shown that progesterone, actually after the first miscarriage, can cause an increased likelihood of a live birth by up to 5%. So progesterone is a hormone that's needed for a successful pregnancy. It causes the womb to relax. It causes the glands of the endometrium, the lining of the womb, to secrete nutrients to help with the pregnancy. So it's a very important hormone. And they found that by giving women who are at risk of miscarrying in their second pregnancy after a first miscarriage, they found a 5% increase in the likelihood of a successful pregnancy. It may sound like a small number, but it is significant, because when you look at the whole population studies and you're looking at millions of miscarriages a year, this 5% actually results in hundreds and thousands of live births. So it is an important figure to have. They've found that women with 3 or more miscarriages, when they do take progesterone in their subsequent pregnancy, they have a 15% increase likelihood of a live birth. So promising data. It shows that there's something that we can do. We don't have to wait for women to have 3 or more miscarriages before we start giving them progesterone or start treating them or start investigating. So these are the barriers that need to be broken down as far as management of miscarriage is concerned. Now, I want to talk briefly about ectopic pregnancy, because that's also another early pregnancy complication. Ectopic basically means out of place. So it's not, the embryo is not growing in the right place. Fortunately, it's uncommon, about 1%, and it can be either conceived naturally or women undergoing fertility treatment. So most develop in the fallopian tube and can stretch the tube, and it continues to grow, and that can cause a rupture of that tube. And when it reaches that point, it's a life-threatening situation, because you can have hemorrhaging, bleeding, and if you don't reach to hospital in time, medical treatment in time, you can die. The risk factors would include things like infections, pelvic inflammatory disease can cause scarring of the tube and cause narrowing and block the fallopian tube. And there is increased risk if you become pregnant whilst on the IUD or coil or on the mini pill. Also, if you smoke, and as I mentioned, fertility treatment, IVF, the women are increased risk of an ectopic pregnancy. So this is just a little diagram of where this fertilized embryo could implant and all the abnormal areas it can. So it can do so in the fallopian tube, okay? It could even do so in the cervix, that yellow embryo there. So there are sites where it implants abnormally, and this is where all the problems are if it does. Even outside of the uterus in the abdomen, which is very rare, you can have ectopic pregnancies. So what are the symptoms like? Some women actually may not have any symptoms. Very few have none. Some women have a few symptoms. They may get some bleeding, a bit of achy pains, and others could have life-threatening symptoms where there's bleeding in the abdomen, they collapse, and they can have pain in the lower abdomen. It could be sudden or gradual in onset. It could be on one side more than the other. You can have vaginal bleeding, which can start off as spotting and become heavier or darker. You can get pain in the tip of the shoulder, and that's caused by blood leaking into the abdomen, kind of irritating the diaphragm, and that's referred pain into the shoulders. You can get upset tummy, especially, and that's a worrying sign again, because it means that there is free blood in the abdomen, and that's irritating your bowels, causing diarrhea. Again, the emergency situation can happen if you have a severe abdominal pain and you collapse due to extreme blood loss. And that is an emergency. You need to seek urgent medical attention. So, any woman positive pregnancy test who are having any of these symptoms, they should be speaking to a health professional. There is a link here for the early pregnancy assessment unit. Again, women who have these complications, these symptoms, can approach their GP, their midwife, A&E, NHS 111. It's just important to seek medical attention with these symptoms. So it's usually suspected if you're between 6 and 10 weeks pregnant. Some women don't even know that they're pregnant. So any sort of low abdominal pain, any sort of bleeding, just important to seek that medical attention to confirm what it is. The thing with ectopic pregnancies, you can have a quick diagnosis. The woman can come in with her symptoms, have a scan, we see where the pregnancy is. It's not in the womb, it's in the tubes or outside the uterus. And you can have a very clear-cut diagnosis from presentation and to treatment. But sometimes it can take quite a long time. And that occurs when it's very early in the pregnancy and you need several scans, several blood tests to actually confirm that it is an ectopic pregnancy. One of the tests they do is a pregnancy hormone test called beta-HCG. So it's produced by the very early pregnancy, and that is checked every 48 hours. And we expect to see a rise of at least 63% in a normal pregnancy. So it's less so in an ectopic pregnancy. So that's one of the blood tests that the doctors may be doing 2 or 3 of those blood tests to kind of determine what sort of pregnancy this is. Sometimes to diagnose this problem, they need to do a keyhole procedure via general anesthetic to see exactly where the pregnancy is, because sometimes a scan cannot show us exactly where the pregnancy is. So treatment includes, it all depends on what your symptoms are, how high your hormone levels are, and what exactly they see on the scan. And there's a subset of women that we can have what's called expectant management. We can wait and see if these problems, to see if the hormone levels resolve, and we basically monitor the hormone levels to make sure it's dropping. So it all depends on your personal views and preferences. Some women, they don't want to wait that long. They don't have enough time to be coming into hospital every 2 days for blood tests. But it is an option for management of ectopic. Then there's the medical management as well. Again, it depends on certain criteria, what your hormone levels are, and what sort of symptoms you have. And then there's a surgical treatment where the pregnancy has to be removed, because, as I mentioned, that a pregnancy can actually grow inside the tube until it ruptures. So you can imagine for a woman who has been through a miscarriage, or who desperately wants this pregnancy, to find out that she is pregnant, but the pregnancy just has no chance of survival. And that could, again, result in quite distressing emotional symptoms, apart from the symptoms of pain, going through an operation. Sometimes it could be very acute, the woman just doesn't have time to process what's going on. And that loss, that feeling of sadness, because she's just lost a very wanted baby. And she can also go through issues with feeling alone, acute anxiety and depression, and anxiety about the future, whether she can get pregnant again, whether what are her chances of having another ectopic pregnancy. We know that there is an increased risk of another ectopic pregnancy once you've had one. So that's 7 to 10%. Hyperemesis gravidarum. This is another early pregnancy complication. Again, it's one of those, the pregnancy is in the right place, is going along fine, the baby's growing nicely. In fact, the babies suffer very little from this problem, but it's the mother that has to bear the burden of this. We know that nausea and vomiting is common in early pregnancy, and most women can cope with it. It kind of resolves by 12 weeks. But there's a subset of women that it's quite severe. They actually suffer severe dehydration and significant weight loss. And a few of these women actually, they get to the point where, they don't want the pregnancy any longer because of the extreme pregnancy sickness that they undergo. So you at increased risk of hyperemesis if you've had previous episode of it, if you're carrying twins, if you're carrying what's called a molar pregnancy, which is an abnormal pregnancy that's mostly placental tissue. You can suffer from signs of dehydration, very thirsty, and you become very drowsy or unwell. It can last up to 20 weeks. And in a few women, it can actually last until the end of the pregnancy. It affects your mood. You can imagine you can't really work, you can't really look after your other children when you're feeling that poorly. Fortunately, there's not much effect on that it harms the baby, but it can cause babies to have a lower birth weight than expected, as you can imagine. Management would include eating small amounts pretty often, avoid foods or smells that trigger the nausea, and complementary therapies such as acupuncture, anti-sickness medication as well can help these women. So again, it's important to seek that medical help. Some women actually need hospitalization, to be given fluids, to be given support, and also these women need counseling as well when they're this unwell. Now, quite commonly, women can experience early pregnancy bleeding that's sometimes painless, but is still concerning and worrying to them. It's common, it's not always, it doesn't always mean because you're having some spotting or some bleeding that it's a problem, but it could be a warning sign of miscarriage, ectopic pregnancy, or molar pregnancy. It could mean that it might be a pregnancy of unknown location, basically that it's a pregnancy that cannot be seen on scan because it's so early, and you may need more scans or regular scans to actually see where this pregnancy is developing and how it's developing. Some women get an implantation bleed, so that's about 10 to 14 days after conception, as the embryo kind of implants into that lining of the womb. It can cause a little bit of bleeding, and this isn't a sign of a problem, and that usually tends to be slight and go away. So early pregnancy bleeding can range from very benign or it could represent something serious, but in most cases it's not usually a problem. So it's so important to look after your mental health after pregnancy loss, even after before you embark on another pregnancy, and while you are undergoing another pregnancy when you've had previous losses. So it's important to the basic things: eating, sleeping well, regular exercise, can all help to benefit you mentally. Some women find mindfulness, things like yoga, acupuncture, help them to keep a calm mind. We shouldn't forget prayers. We shouldn't forget, it's very important in the Black community, our religious aspect, and how this can play a significant role in our own well-being. It's important to help improve your self-esteem, because you can look at your body as, oh, I failed, my body has failed me. And you will need to put back some self-esteem into your life. First of all, giving yourself some time to grieve. Also, some women have found that reading other people's stories, reading what other people have gone through, has been beneficial to helping them get over their own grief. And don't forget kindness, being kind to oneself. Trying to start a new skill or hobby can also help take your mind off of what has gone through and help your mind to heal from what you've just gone through. It's important to have counseling. Some women feel, need it. Some women feel they can just speak to their partner or their friend or their faith leader. But the counseling has, women have found that counseling has helped tremendously. So there are counselors available at CAHN, which is this group, to offer support to women. You can see counseling through the hospital, the early pregnancy unit that you've been through your GP. Self-referral program, improving access to psychological services is also one of the options. And there's a specialist counseling charity called Petals that helps women who have had pregnancy and baby loss. And some places of work offer free counseling to their employees. So please also explore these areas as well. So in summary, early pregnancy complications can be distressing. It's important for us to talk about it as women, as members of the Black community, because we now know that 43 to 60% increased risk of having a miscarriage compared to our white counterparts. And it's heartening to know that there's research ongoing as to why this is taking place, but we need to also take in mind that there are different things that we can do to help prevent those risks. We know that certain early pregnancy complications can be life-threatening, so it's important to seek that medical help when there's any symptoms like pain, like heavy bleeding, that you're concerned about. And yeah, it's so important for us to really come together as a community and talk about these problems and how we can help ourselves to solving these problems. So thanks very much for listening. I know that there are going to be lots of questions, and I'll just hand back over to Dr. Appiah.
Thank you so much, Dr. Arthur. I'll, whilst you're stopping sharing, just to say a huge thank you, and thank you for the detail in explaining it, but also the sensitivity in it, because it is a particularly emotive subject, so really done so sensitively. So again, thank you very much. And I really want to give an opportunity to people to put their questions in the chat. to also feel free, please, to put up your hand and ask any questions. This is a really safe space, but it's a safe space for you to explore any things that you want more clarification on, more detail, or just to reflect or share experience. So please do feel free. And you can also message me privately if you'd prefer. But whilst we're waiting for questions to come, other questions to come through, one of the things that someone has just earlier, when you were talking about something that resonated with them was the feeling of that your body has failed you. And I can really attest to that, that when you've had one miss, whether it's one, whether it's multiple, you do have a sense that, what is wrong with me? Why can't my womb hold this fetus? Whereas I have friends, family who, pregnancy is no issue. And I think this person just said, just thank you for reminding everyone to be kind to yourself, because I think in our communities, self-care, I don't think that we prioritize enough. So just giving you some time to build upon that.
Yeah. Again, this is a topic that, we hardly speak about in our community. And, even myself, I've gone through miscarriage, and I remember going through it and just getting back to work the next couple of days, and you don't really process it. And I think it's important that, I think because we accept it as being a part of womanhood, we accept it as it's common. Some people believe, because you probably lift up something heavy, that's why you miscarry, or we don't really understand that it definitely has a reason. There's a reason sometimes behind it, not just it's genetic and that's why I miscarried. As I mentioned, it's 50% of that. So that means the other 50%, there's a cause. And these researchers in Birmingham believe that there is a lot more that can be done to help those various causes as to why miscarriages happen. So that's why I think I need to stress that it's important to be kind to yourself, because it's not your fault. It's not your fault. Most women that I know in our community, they don't really smoke or drink or, have these lifestyle issues. And if further investigations are done, perhaps we can find a cause and a reason as to why it's happened, and make some lifestyle changes for the next time that comes around. So really, it's important to remind yourself that the body is very resilient, the mind is very resilient, and with the right information, with the right support, your body can do amazing things. So just keep that in mind when going through a situation like this.
Great. No, thank you. I like that about our bodies being able to do amazing things, and definitely surprise us as well. So no, thank you so much. And please keep the questions coming through. So another question is about hyperemesis. And the question is this more common in Black people? And what are the most typical treatments for it?
Mm-hmm. Well, in my research, I haven't found any evidence that is more common in Black people. So I think it's something that it happens throughout the reproductive age group of women through early pregnancy. But as I said, it's common to have nausea and vomiting, early morning sickness. That gets better around 12 weeks. But a very few percentage of women, 1 to 3%, have this really severe protracted vomiting and nausea, where they get weight loss and they get severely dehydrated. And my advice is perhaps to seek medical attention before you get to that point. I know a lot of women don't like being admitted to hospital because they've got other children that they're looking after, they've got other responsibilities, so they think they can just go on and on and on. But the first thing that we do is start giving you some fluids. And we when it comes to that point where you can't absolutely keep anything down, we'll give you some fluids to replenish that, give you an anti-sickness medication. Some women have found that ginger, some ginger products, some supplements can help, but it can also irritate your tummy if your tummy is completely empty. Sometimes it can cause a bit of irritation, but it's something you can try. Ginger tea, to see if that can help. But sometimes you just need medication, drugs to help reduce that sickness, so that you can then put back in what you've lost. So treatment wise, anti-sickness medication, we've got acupuncture actually called acupin. It's something that we teach our patients to use that has been known to help women control their vomiting, their nausea and vomiting in pregnancy, and it's been found to be successful. So we use that in our early pregnancy unit, and I believe other hospitals as well, like St. Mary's Hospital, also has that treatment. So we actually give the patients the kit to go home with, so that they can treat themselves. And some women have found that quite useful. So it's a non-drug method of treatment of hyperemesis. When it gets really bad and you're in hospital, they can offer you steroid tablets, and some women may need to take this for a few weeks, others until the rest of the pregnancy. But this is very uncommon, for it to get to that stage. Majority of women, once they get treatment from hospital and they're able to tolerate some sort of anti-sickness tablet, they can then go home and continue with the rest of their pregnancy, and hopefully by at least 20 weeks or so, they can then start tolerating their diet much better. And as I mentioned before, small frequent meals, so and basically bland foods as well. So stay away from the spicy foods. So just stick to the plain carbohydrates like bread, biscuits, that sort of thing. You just need that little bit of energy from those sort of foods to get by in the first trimester, especially.
Thank you. I think it's such important information to share, because it is something that I think so many people don't know. As you say, it exists, or like exactly as you said, just plod on with something that can be so intrusive in their life. And I know that one of the questions, but you've answered, was related to the medications, but the person had hyperemesis but was scared to take anything, because we are conditioned that we shouldn't take any medication in pregnancy. But I think you've answered that, and I think that in these cases, is it safe to say that it's been used significantly in pregnant women? Otherwise, it wouldn't have been suggested for use.
Yeah. So our first line medication is cyclizine, and that has a really good safety profile in the first trimester. The second line on dantrotone, we try not to use that in the first trimester because there's a small risk of fetal abnormalities. But this is something we explain to our patients, or we should be explaining, so that we build that trust and rapport with our patients, that we definitely want to see them get better. And sometimes that is just, sometimes we see such a big difference from when they come in to when they leave. And, we put it down to good care, really, hydration, just helping them to keep their food and drink down with anti-sickness medication. So sometimes that's the only way. And I haven't come across really any fetal abnormalities in using this, these medications to help with anti-sickness.
Thank you. And hyperemesis, lots of questions. So I promise I'll go on to the other topics, but I just want to kind of bring each kind of topic area together. Mm-hmm. So there is a question about whether hyperemesis is age-related or psychological. And they've noticed that some pregnant girls do not get it. And I'm presuming the term that's used is because younger pregnant girls may not get it. So could you just let us know if it is age related?
I don't think so, but I do know that women who are having twins, sometimes women, as we mentioned, the molar pregnancy, they are more at risk of getting hyperemesis. I haven't come across any like age-related risk factors in hyperemesis, but there are certain conditions where people will get it more than others. So in those situations, yes.
Great. And just to kind of clarify, we don't think it is psychological.
It's definitely not psychological. It's something physiological. It's caused by the hormones of pregnancy, causing that nausea and vomiting. So it's not psychological at all. It's actual physical, and it could be life-threatening if the woman doesn't seek medical attention. So it can be quite severe.
Great, thank you so much. I think it's really important to kind of move any myths or any other inaccuracies. That's fantastic. Thank you so much. And thank you everyone for the questions. So another question is, and I know you've mentioned it a couple of times, is what exactly is a molar pregnancy?
Okay, so molar pregnancy is basically abnormal pregnancy tissue, and that can be caused by 2 sperm fertilizing 1 egg. It just doesn't develop into a baby, okay? It basically produces lots and lots of the pregnancy hormone that again can have that effect on you. So high hormone levels can cause that nausea and vomiting. It can be caused by a sperm fertilizing an egg that doesn't have any genetic material in it again. So again, it's not a embryo that can develop into a baby because it just doesn't have the genetic material. So it could present as a pregnancy. It is a pregnancy, but it's abnormal tissue, and it's usually confirmed by histology. So when that pregnancy tissue is removed, it goes to the lab and they confirm that it is a molar pregnancy. So again, it's something that needs specialist treatment, specialist care. You need to be followed up after that pregnancy to make sure those hormone levels come down to normal. And if they don't, you would need further treatment for that.
Great, thank you so much. And someone's picked up that you mentioned about the economic cost of miscarriages. So they just wanted a bit of clarification about that, please.
This is what I picked up in this study, and I believe it reflects the income that women have lost because they cannot go to work. They can't earn an income. Most of these women, if they don't turn up to work, they don't get paid, or because they have to take sick leave for such a long period of time. After a certain time, their job doesn't cover them for that. So it's down to lost income, the economic cost, and also the cost of getting the hospital care that they need, getting the scans, getting the treatment to treat the miscarriage once it happens. That's one thing I didn't get into, like treatment of miscarriage. and the different options that are involved. So yeah, so it encompasses all those different costs. It's quite a hefty bill.
Great, and I think that whole aspect of the financial loss that we don't really talk about in the, as you say, days off work, or less productivity when you do go back to work, or you're at home, and what you could do in a day or 2 days will take you much longer because energy wise, mood wise, you're really affected by what you've been through. And I think and that can also just impact so many other people within our lives that we don't often really discuss or acknowledge. We know that they're there, but it's often focused very much on the woman and what they're going through. And I wanted to just draw that because I've had a private message, and I won't share the name, but I really want to thank them for sharing their experiences. And I'm just going to give an overview of what they shared. So first of all, they're just thanking you for informative presentation. But this person has been through 5 miscarriages and didn't have any investigations. And sadly, these were all quite late. So around 22 to 24 weeks, including twins. And again, just so sorry for what you've been through your motherhood journey. But this person is just commenting, first of all, that how helpful things are now that we can hear each other's experiences and share it and take these issues on board. This person was able to have 2 children later on, but really acknowledges the importance of these conversations. But something that she says picks up on what you've just said earlier is that we must remember the men in these cases and what we do to support. So just wanted to get your reflections on that, please.
Yes, I think this is something that, again, we don't really talk about much in miscarriage circles, what the men go through. And I myself, I'm guilty of that as well. And I think, yeah, it's important that we bring that topic up. But men do feel that that they can't help their partner. Some men are absolutely lovely in supporting their partners. Others take a step back and because they feel so helpless. And it's important we involve our partners, the men that are involved because it's their baby as well. And it's important that we involve them in the conversation about miscarriage and how they feel as well, and what they can do to support their partners. Again, it's something I need to delve into that myself. But the Miscarriage Association, they have actually support services for families, not just the women, but for the partner and the other children involved as well, because it affects the whole family unit, the grandparents, the aunties, the uncles, the whole family unit it affects, because everybody is looking forward and with expectation to this baby that unfortunately has passed away. So is important. It's definitely something we need to come to terms with, get our men involved with.
Thank you. And another message that's come through to me is really asking how can we create more spaces to have conversations like this, and are there more digital spaces that exist, and if not, how can we galvanize our community to talk more?
That is something that I need to sit down with CAHN and come up with something that can be useful in our society, in our community. One of the things is that CAHN gave me the opportunity Charles, he gave me the opportunity to talk about anything I wanted to talk about. And I chose this because it's not something I hear about enough. It's not something I hear about often. Yes, I do see patients coming in with miscarriage and I have to treat them, but I wanted to more delve into the emotional aspect of it. And I realized there is so much into that, and there's so much into sharing one's stories. That is such a healing process when you speak to each other. So now in the digital age, we have women actually going on Instagram and sharing their stories, but I know this may not be for everyone. Not everyone wants that kind of publicity. It's definitely important to have these small groups, coming together to discuss what people have gone through. And, for example, that lady who told me that had 5 miscarriages and no investigations. I mean, that is just shocking. That's really, really shocking. Again, maybe if she were in a support group, they would have shared their stories, women would have shared their stories and advised her, to go to a GP and get a referral and get some investigations done. But really, no woman should go through that in this day and age. We need to
Thank you.
each other. Yeah.
No, completely agree. And someone's just also written, I think it's more of a comment or sharing an experience that they were shocked after they'd had their miscarriage that they were kind of left alone. So after if you do have a successful pregnancy and outcome, you have your health visitor, you have your postnatal checks, and I know this as well, that depending on the number of weeks, you can often fall into a gap that there's no other conversation. And unless you bring it up in the consultation, it's not even really addressed. And I always used to remember, I found that quite distressing, that I would have to either repeat your whole obstetric history, or that even when you did talk about it, some of them were dismissed and it wasn't taken forward. So I think this person just wanted to kind of highlight that.
Yeah, so definitely we as clinicians, we need to definitely be more sensitive to women coming forward with this history of miscarriages, recurrent miscarriages, stillbirth, pregnancy loss, ectopic pregnancy. It's so important that we hear their stories, and as women clinicians ourselves, we're in a really good position to understand what these women are going through and to point them in the right direction. Definitely speaking with someone who's been through a similar situation and who has positive ways of helping you to deal with it is definitely the way to go. So, I just encourage women to we can share the links, the websites that I shared in my presentation about support groups. And it's daunting, isn't it, to share certain stories with strangers. That's a daunting thing. But I think we all know, as a group here, as a group of women here, we all know someone who who's going through a pregnancy now, going through a difficult early pregnancy with the nausea and the vomiting and the hyperemesis, who have gone through a miscarriage, have gone through a pregnancy loss. We all know each other, and we have that responsibility to each other to support each other. So yes, we can share links, and we can come together and share our stories. And I think that's important in the healing process, to talking, communication, very healing, very positive.
Definitely. Thank you so much. And again, I just want to thank everyone for the private messages that are coming through and just being really open and honest and sharing. And I think we've got time for just one other question and reflection that's come through in the chat. And I'm aware it's a specific question about this person's experience, but I think just to bring it up and then whatever you feel comfortable in responding to it. So the question is, after giving birth to my last baby, I had an implant and that lasted for about 2 years, 10 months or so. It was then taken out, and soon after she became pregnant, but after 2 to 3 months had miscarried, and an injection was given to her in the hospital. Since then, she hasn't been able to be pregnant again and wonders if anything in that circumstance has had a hand in it.
Yeah, that's a very, very good question, and I'm sure this lady would have thought about that over and over again. So it's so important to when those things are happening, to have a follow-up. But I know it's difficult to get, even to get hold of your GP sometimes, far more to to get answers to questions. But as patients, we have a right to seek answers to things that may have happened to us. We can actually write to our early pregnancy unit asking these questions. What injection did I get? What was it? What did, why did I need it? Was that absolutely necessary? So we have that right to ask these questions, and we do have a voice, and it's important that we recognize that. And I don't know how long ago this happened, and so I don't know if these notes are still available, but it's something for women that are going through that to actually speak to their clinician. And even if it's to make an appointment later on after everything is done, because that's what we do for women that have had a stillbirth. We usually follow them up in and discuss what had happened and how we could prevent it in the future. So I think that should be opened up even to women who have miscarried. That face-to-face talk, honest talk with your gynae consultant or gynae doctor as to what could I have done, or what happened, or why did it happen. I think we need those honest conversations with our doctors. So yeah, without knowing exactly what the injection was, it's difficult to say, but it's important that this lady gets those answers and perhaps tries to speak to her early pregnancy unit.
Thank you so much. And I think, that actually kind of is a really good place to end, just emphasizing that aspect on empowerment. And yes, if you're in a situation and you don't feel that you've received the care that you need or deserve even, then please, after being in spaces like this, recognize that you do have power and you are able to go and ask questions and say, I'm struggling to understand XYZ. I want to understand. I need to know. And don't feel that you have to sit, as you say, thinking about it in loops, and because you'll never come to the answer because you haven't got the information that you need. So no, I think a really powerful way to end. Dr. Arthur, thank you so much for today. Thank you for, again, your articulation, your sensitivity, and just answering all these questions. And I can see from the engagement that people have really welcomed this discussion. As you say, we simply don't have enough discussions about these. So, and thanking everyone that has taken the time out of their Saturday morning to listen and take part. This is for you. If you haven't had a chance to watch it all, or you think after listening, it's important that you share with friends and family, please do share the YouTube link, the Facebook link to friends and family, because it's not just about keeping the information within us in this group, it's about cascading it to everyone else. So right now, I'm just going to hand over to Percy, who's just going to give us a bit of overview and some announcements. So, but thank you once again, and thank you, Dr. Arthur.
You're welcome. Thank you.
Many thanks, Dr. Vanessa. Very much thanks to you really for anchoring the program really well once again. So massive thanks to you. And also to our doctor, Dr. Patrice. I mean, this is a topic that's very sensitive, really, not just for our women, but also for the men as well. We definitely do know people that have gone through this and are even going through this really, and various aspects really. So very much to say thank you to you for doing great justice to that topic. So just a couple of things we've got, coming up. So next week, same time, same place, we've got another health hour session. This time around, it's just building up on one of the conversations we had previously, which is on sleep. So please do endeavor to join us. This is a part 2. So if you missed the first one, make sure you don't miss this one really. So please tune into that as well, same time as well. Then the other thing to draw attention to is our Healthy Hearts program as well. So this happens on Tuesday evenings. So please endeavor to join. It's all about food and nutrition really. And this week it's talking about how to take care of our sick people really. So in terms of feeding and all that. So do endeavor to join. Then another event coming up, one of the flagship events at CAHN. Building up from the discussion we had today, really focusing on women's health. This one, it's on the 8th of March. It's the International Women's Day. It's focused on empowering Black women really during menopause. So it's an all-day event in Manchester at the Limelight. We've got the details of the event, further details, so that'll be put in the chat box. So please feel free to attend, register. There are different delivery points for it. So there's like a conference at the beginning, there'll be stores, there'll be food as well. So please endeavor to join into that. Then also as well, I know we've mentioned some of the services that one of our partners, that's CAHN, they run. So this is the advocacy service. Currently there's a fundraising campaign going on. So please do feel free to key into that really, kindly donate to support. Really lots of great work being done there in terms of advocacy, housing and all that really. So do endeavor to join in. Then moving on similarly to the advocacy and other support services that are available. So thanks for that. Then the other service to mention as well, which is in-house, there's a bereavement and a peer support group. They're running a program between the 9th of March to 17th of July, really. So do endeavor to look at that really. Lots of brilliant things to cover there around providing practical support for people that are recently lost a loved one or are struggling with grief really. So that's in there. Then another service just to mention as well is the Green and Arts Wellbeing service, and a new service really in CAHN. So please do endeavor to key into that as well. It's all about using green space and arts, but then African and Caribbean culture as well, and bringing those things into developing our general health and well-being. So please feel free to key into that. Then just to say, before we go, a massive thanks really to all the CATHIP partners really for bringing this together. So starting from CAHN, we've got as well the Enfield, we've got, I think we missed that. Yeah, we've got our Enfield Caribbean Association. Just say massive thanks to them. Rafa International Development Agency, the Royal Assembly Redeemed Christian Church of God down in Sheffield. We've got Croydon BMA Forum and also the Black Health Initiative in Leeds. So just say massive thanks to all our partners. Week in, week out, they do great job really in terms of pulling this all together for us also. Just say massive thanks to our partners, and we look forward to seeing you again with us next week. Do have a good weekend. Bye now.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will will include other panel members, such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.